Ma'am, we ready? 5, 4, 3, 2, 1. Ma'am, you're live. Go ahead.
Very good evening to all of you who's joined here for the next generation webinar. So this is an initiative in collaboration with Society of Fetal Medicine. So without wasting any more time, I will hand it over to Dr. Ashok Khurana to begin the proceeding. Thank you all for joining today. Over to you, sir.
A very good evening, everyone, and welcome to the first of the new version of our Society of Fetal Medicine NetGen Experts webinar. With the response that we got with the first few in this series, we realized that we had made great strides that we had not been able to appreciate about ourselves. We're only in our 15th year, and we were getting crowds of over 600 to 800 people for the Next Gen Expert webinar. These were actually designed to let us know how best we can use fresh minds to tell us not only about old wine, but new wine, and also new wine in old bottles and old wine in new bottles. And we realized that this was something that was fitting in very well with the current method of understanding and learning of not only the newer people in the field, but also the established people in the field. We've been quite busy for a few years trying to make sure that the usual suspects, the so-called serious people, were actually, and the senior people were actually getting to teach us. And this is now undergone a radical change. We now walk shoulder to shoulder between the youngest, the senior most, and everybody in between. And that's where the next gen seems to have fitted in beautifully and filled in what we never even realized was a gap. I was indeed, it was a great moment of pride for me, I should say, when GE decided that, yes, we will put this on the international circuit and we will expand it to include as many numbers as we possibly could. And here we are today. We have 5,500 members and 1,480 plus have registered for this program. Congratulations to each one of us at the Society of Fetal Medicine. Let me also at the outset thank Alok Varshini for having got this idea rolling, to Mohit for having approved of it so wholeheartedly, and for Bimal for inspiring us first, Dr. Bimal Sani for first inspiring us to go outreach, which is way into the background, and then taking this giant leap forward with the help of Mohit to reach the future. Thank you indeed, all of you, and a very special thank you to GE for hosting us for this series of the SFM Next Gen Experts webinar. And over now to Alok Varshini for taking this forward.
Good evening, everybody. First, I would like to invite Mohit sir to welcome the delegates and the attendees, and then we will continue with the rest of the webinar.
Yeah, good evening, everyone. It's such a proud moment to have you welcome for this unique webinar. As you rightly said, we'll have speakers somewhere in between, but who have been, consistently speaking in the platform. We know their work, but it's time they showcase their advanced work in today's webinar. I thank GE also for partnering with SFM to reach out to as many people as we can, and we are truly going international this time. And we welcome you all to have a glimpse of what the future, SFM future holds for all of us. Over to you, Alok.
Thank you, sir. Once again, good evening to everybody. And today we have an academic feast waiting for us. And it is very, very, proud moment for me, because this time the topic is cardiac, and we love cardiac imaging, and we have selected 3 of the most versatile people who are shining stars in the field of fetal echocardiography. And it is also important to note that these three people, they do not come from tier 1 or tier 2 cities. They work actually in tier 3 cities, small cities, but their levels of imaging, the level of commitment they show when they're working up their cases, it is absolutely amazing. So I hope all of you enjoy listening and seeing their wonderful cases. And so the first talk is by Dr. Sunil Kabra. Dr. Sunil, please share your screen. So Sunil is a consultant radiologist at Kabra Sonography and Fetal Echocardiography Center at Yavatmal, Maharashtra. And he has had various stints at various government colleges, and he has had training at various foreign locations at Jefferson University, Philadelphia, USA, Singapore, and even in London under Professor Kypros Nikolaidis. And he is in great interest in fetal echocardiography, and he is a fantastic speaker, speaks very frequently at international and national conferences. And today he'll be speaking about the twists and turns of venous abnormalities of the heart. So over to you, Sunil.
Thank you, Alok. Thank you very much. Good evening, everybody. First of all, I would like to thank the SFM team, the President, Secretary, Dr. Khurana sir, Dr. Mohit sir, and Dr. Bimal sir. Thanks for encouraging and giving me an opportunity. Now, today's topic is on venous anomalies of the fetal heart. Just the slide is stuck. Okay. So venous anomalies of the fetal heart are rare and difficult to diagnose. When not detected, they have potentially a poor outcome. These anomalies of the fetal heart can be detected on standard views of the fetal heart. And if you follow a standard protocol, you can diagnose most of the venous anomalies of the fetal heart. But when detected, you have to plan the delivery at the tertiary care center where the pediatric cardiology team is there, and they can attend so that the mortality is reduced significantly. Now, venous circulation of the fetal heart, it may be systemic, pulmonary, and umbilicoportal venous system. And to detect the veins normally, and for the abnormal venous connections, you have to go for a proper machine setting is also very important. And especially for the color Doppler, you need a low flow settings, low PRF, and increased color gain with a wall filter. So venous anomalies of the fetal heart, in this section, we discuss about the pulmonary veins, inferior vena cava and superior vena cava anomalies, because these are very, very important veins of the fetal heart, and especially the pulmonary veins. So normally pulmonary venous returns in the fetal heart. So 4 pulmonary veins, right and left superior vena cava, superior inferior pair, they drain the lungs into the posterior wall of the left atrium. Okay, so right superior and inferior pulmonary veins and left superior and inferior pulmonary veins. So when you take a proper 4-chamber view, and if you see area behind the heart, you will see a small tiny veins which opens into the left atrium from the posterior aspect. And when you put the color, and you have to proper setting of the color with a low flow, PRF is up to 5 to 20 centimeter per second. Here the PRF is 11 centimeter per second. You will very clearly appreciate the pulmonary veins. Normally the 2 pulmonary veins, right and left inferior pulmonary veins, are visualized in the apical 4-chamber view. But if you take a proper oblique section of the 4-chamber view, sometimes you can see all the 4 pulmonary veins, right superior inferior and left superior inferior pulmonary veins in the same section. These are the pulmonary veins, superior and inferior pulmonary veins in the same section. 4 pulmonary veins are detected. We called it as a crab sign because all the 4 legs of the crab, it looks like all the pulmonary veins. So the vein with an adjacent pulmonary artery was the superior pulmonary vein. So superior pulmonary veins always runs along with the pulmonary artery, and the vein without an artery adjacent to it was the inferior pulmonary vein. Then you have to take a look that whenever you take apical 4-chamber view, basal 4-chamber view, and lateral 4-chamber view, on all these sections, we can very beautifully see the pulmonary veins. Normally, you see the 2 pulmonary veins very carefully, and this is the standard protocol as per the ISCG guidelines. But sometimes when you take a lateral 4-chamber view and put the color, you can see the 4 pulmonary veins at the same time. Now, after that, you have to see the area behind the heart. This is the very, very important part regarding the pulmonary venous and pulmonary venous anomalies. So when you take a four-chamber view and when you see the area behind the heart, the distance between the posterior wall of left atrium and the descending aorta is very, very narrow. The another descending aorta can't fit in between that. So this is the very narrow. If the space is increased, it gives the hint that you are dealing with the pulmonary venous malformations. Second thing, you have to calculate the post-LS space index also. What is that? It is the left atrial to descending aorta distance. From left atrium to descending aorta, take one measurement, and another is the diameter of the descending aorta. If you take and divide by this descending aorta, the ratio comes is the post-LS space index, that is normally 1.27. If it is more than that, then you can suspect something abnormal in the pulmonary venous. These are the very beautiful images. You have to just a color flow setting is very, very important to detect the pulmonary veins, because these are very tiny veins, very slow flow. But if you take a proper imaging, then if you take a color box properly placed, especially you don't place color box in whole of the four chambers, you just put the color box in the atrium and the lower portion of the atrium where the pulmonary veins enters. You can beautifully see the pulmonary veins. Now after that, you have to take the spectral Doppler. How will you take? Then once you see the pulmonary veins, put the cursor in the lung at the level where the pulmonary veins enters into the left atrium. Once you put that, then you take a spectral Doppler, and it is similar to that as a ductus venosus, like S, D, and A wave. This is typical. The same pattern is of ductus venosus. If anything, that is a triphasic spectral pattern. If there is any obstruction or anomalous pulmonary venous malformation, then the triphasic pattern is lost. Then the most important thing is that left atrial commodus ridge. When you take a four-chamber view, you see a tiny echogenic foci in the left atrium. So what is that? This is the muscular ridge of tissue that lies in the left atrium. It is at the junction of left superior pulmonary vein and the left atrial appendage. If this is present, then you will rule out the TAPVC. Okay, this is the very important structure. So TAPVC, total anomalous pulmonary venous, are two types. So it is a rare form of congenital heart disease in which all the pulmonary veins, they connect to the systemic veins or the right atrium or both of them. So the incidence is 0.5 to 2% of the congenital heart disease, and the ratio is 1 to 14,000 to 1 in 17,000 live births. So detection rate is very, very low, only 1.9%. Mostly the isolated cases are missed. So if you follow the protocol, if you see the area behind that, you can detect the anomalous TAPVCs, and then the incidence, the detection rate is increased. So there are two types of anomalous pulmonary venous. It is a total or a partial. In total, all the four pulmonary veins, they drain into anomalous location. They drain into the right atrium or into the systemic circulation. But in partial anomalous, either the one, two, or three of the four pulmonary veins, they enter into right atrium. Here in this, like this, the right pulmonary veins, they drain normally into LA, but from left side they drain into the brachiocephalic vein and into the superior vena cava. So this is the partial variety of this one. So come with a total anomalous pulmonary venous condition where all the four pulmonary veins opens into right atrium or systemic circulation. There are four types. Type 1 supracardiac, type 2 cardiac, type 3 infracardiac, and type 4 is a mixed type. It depends upon the opening of the pulmonary veins into anomalous location. So type 1 is the supracardiac type, which is the most common type of TAPVC. In 50% of cases, there is a supracardiac type of this one. So what is the simple rule for the diagnosis of TAPVC? So the most important, the major criteria for that is the absence of connection between the pulmonary vein and the left atrium. It is the most important and major criteria. But if you find another minor markers or minor criteria, these are the presence of vascular confluence behind the atria. If you find the confluence of pulmonary veins behind the atria, then you suspect that there is abnormal in the pulmonary veins. If you find an abnormal spectral pattern of the pulmonary veins, then you have to search for that abnormal location. Then if you find a smooth posterior wall of left atrium, or increased retroatrial space, or a dilatation of the coronary sinus, then you suspect that it is a type of cardiac type of TAPVC. If you find a dilatation of the superior vena cava or brachiocephalic vein, then you suspect it is a supracardiac type of TAPVC. Once you see the minor criteria, then you have to go for and search for the direct major criteria, whether the pulmonary veins are opening onto left atrium or not. So most important, most common is 50% of cases is the supracardiac type of TAPVC. Whenever you find the confluence of the pulmonary veins behind the left atrium and that drain into a vertical vein and through that into SVC, this is the supracardiac because the venous connection is above the heart. So first case, how will you suspect, how will you detect the supracardiac type of TAPVC? And these are the few images, few videos I will show. In first, what are the findings in first 4-chamber view? Then the most important, if you see the left side of the fetal heart is the left atrium is small, left ventricle is small. Second, the left atrium, posterior border of left atrium is smooth one. Okay. Third thing, the distance between the descending aorta and left atrium is increased, and in between that, a transversely oriented vein is seen. Hypoechoic structure is seen, and if you place the color, you see a color flow in that. It is done. We called it as a twig sign. Then this gives an hint that you are dealing with the abnormal connection of pulmonary veins. Then you have to take a 3-vessel trachea view. Then in 3-vessel trachea view, what you see, the superior vena cava is dilated and enlarged as compared with atria, because normally we compare with the aorta. So superior vena cava is dilated. So two findings are there: increased distance, twig sign, color flow, confluence of the pulmonary veins, and superior vena cava dilatation. This gives hint that you are dealing with the supracardiac type of TAPVC. Then you take a multiplanar approach and take a bicaval view. In this bicaval view, you see that the superior vena cava is dilated as compared to inferior vena cava. One hint. Second thing, when you see that this confluent of the pulmonary veins, it is stressing and opening into the superior vena cava. So blood flow from the pulmonary veins drains into the superior vena cava. So this is the supracardiac type of TAPVC. Then comes cardiac type of TAPVC. In cardiac type of anomalous pulmonary venous return, it may open into coronary sinus or may directly into right atrium. These are the very important things. So this one is the coronary sinus, which is behind the heart. So before that, you must know about the normal coronary sinus. When you take a 4-chamber view of the fetal heart and take a slightly lower section, you see the coronary sinus. Very tiny transversely oriented hypoechoic structure is a coronary sinus. This is normally less than 2 millimeter. But when you take again a 4-chamber view and just above that, you see a circular structure along the lateral border of the left atrium. This is the coronary sinus. Normally it is up to 3 millimeter. If you find a dilatation of the coronary sinus, if it is the diameter is more than 3 millimeter or 4 millimeter, then, and if there is no persistent left superior vena cava, then you have to search for the abnormal connection of the pulmonaries. This is the case, is cardiac type of TAPVC. This is a 4-chamber view of the fetal heart. So all chambers looks normal except okay. Left atrium is the posterior border of left atrium is smooth one, and if you see carefully, the distance between the descending aorta and left atrium is increased. So the area behind the heart is increased. This is the first clue that you are dealing with the anomalous pulmonary venous connection. Second, then when you move the probe upwards and take a 3-vessel trachea view, and in that case, if you see a superior vena cava, aorta, and pulmonary artery arrangement is normal and the dimensions are normal as per the criteria that superior vena cava is always less than aorta. So superior vena cava in this case is not dilated. So one hint is that there is increased space. Second, but the superior vena cava is not dilated. So we rule out supracardiac. Then we take again 4-chamber view and see carefully that this coronary sinus is dilated. But if you see carefully, the confluence of the pulmonary veins, behind the heart is communicating with dilated coronary sinus, and that opens into right atrium. So this is the cardiac type of TAPVC in which it is the coronary sinus which is a draining vein. Another, again a 4-chamber view of the fetal heart. Here you see there is a atrioventricular septal defect, one thing. But if you see carefully, the area behind the heart is not significantly increased, but the confluence of the pulmonary veins are not opening into LA, but these are going directly into the right atrium. So this is the confluence of pulmonary veins directly into right atrium. There is not dilated coronary sinus. Okay, second thing, in 3-vessel trachea view, you see a superior vena cava is not dilated normally. Trachea is normal, only single great artery is seen, aorta. And when you take a sagittal section, you see the parallel vessels running parallel to each other with a small size pulmonary artery. So it's a TGA type. Double alternate right ventricle with pulmonary stenosis. So TAPVC with DORV with the cardiac type of TAPVC. So these are the pulmonary venous connections. TAPVC are isolated varieties also, or associated with various congenital cardiac anomalies also. Now comes infracardiac type of TAPVC. It is again a rare type. So what happens in this? All the four pulmonary veins, they confluence behind the heart, and then a vertical vein, confluence vein, it descends downwards, crossing the diaphragm, and it enters into the pulmonary vein or inferior vena cava. So it is an infracardiac type. All the four pulmonary veins draining into systemic system. So these are the confluence of the pulmonary veins, goes downwards vertically, crossing the diaphragm, and then open into the pulmonary portal vein or inferior vena cava. So when you suspect infracardiac type of TAPVC, first, when you take a 4-chamber view of the fetal heart, and if the area behind the heart is increased, if the smooth LA left atrium, if you see the confluent vein behind the heart, but no dilatation of SVC, no dilatation of coronary sinus. So you suspected that there is a TAPVC, but the coronary sinus or SVC are not dilated. It means that the vein is draining somewhere. Then you have to search for the vertical vein. And if you see the vertical vein crossing the diaphragm, then it enters into portal or hepatic, then it is an infracardiac type of TAPVC. This is the case. This is a 4-chamber view of the fetal heart in which LA is small, smooth, and if you see the distance between the LA and the aorta is increased. So there is a confluence of pulmonary veins. Okay. Second, when you take a 3-vessel trachea view, the SVC is normal. But if you see the aorta, pulmonary artery is small in size, aorta is enlarged. There is a VSD with overriding of aorta also. So thing is that here in 4-chamber view, you suspect that there is a TAPVC. Okay. Then SVC is not dilated, so you rule out supracardiac type. Coronary sinus is not there, you have to rule out cardiac type of TAPVC. Then you have to search for the vertical vein, which is going downwards. So take a sagittal section, and if you see the artery or vein between the heart and descending aorta, that is the vertical vein. So this is the vertical vein which is crossing the diaphragm. So when you put the color and see the direction of the color, it is towards the inferior vena cava. It is upwards, red color. So this is the vertical vein crossing the diaphragm. So it's a infracardiac type of TAPVC. So confluence of the pulmonary veins, vertical vein crossing the diaphragm and opening into inferior vena cava. So infracardiac type of TAPVC. Another here, a 4-chamber view, left atrium small. Only thing is that the area behind the heart is increased. So distance between LA is D. This is the most important hint we get. Then in 3-vessel trachea view, all the vessel arrangement and size is normal. So when you take a sagittal section and if you see a vertical vein crossing the diaphragm and the direction of flow is towards the inferior vena cava, then it gives the hint that you are dealing with the infracardiac type of TAPVC. So in this case, the vein is draining into the pulmonary, the pulmonary veins are draining into the portal sinus. So infracardiac type of TAPVC. Now TAPVC is also associated commonly with the right isomerism. Okay, so we have discussed about the isolated variety, discussed about the congenital heart diseases association, and then lastly, it is common association with the right isomerism. When you take a transabdominal section, and if the descending aorta and inferior vena cava on same side, we called it as a juxtaposition of the IVC. So the stomach, in this case, the stomach is on right side, and this IVC on descending aorta is on left side. So when you draw a line, horizontal line, dividing the abdomen into 2 parts. So if you see the inferior vena cava and descending aorta on same side, this is a juxtaposition. Then you move the probe upwards and see the cardiac section, you get a atrioventricular septal defect. Area behind the heart is increased. So there is a stomach is on right, heart is on left with a complex cardiac defect, and area behind the heart is increased. Then you have to search for the drainage of pulmonary veins into the location. So when you take a bicable view, the superior vena cava is dilated as compared to the IVC. And if you see carefully, the draining veins, confluent of the pulmonary veins opening into SVC. So this is the case of right isomerism. TAPVC is commonly seen in right isomerism. Now comes partial anomalous pulmonary venous return, in which all 1, 2, or 3 of the pulmonary veins drains of the 4 into another location. One of the vein is directly drained into left atrium. So the most thing important is scimitar syndrome, in which what happens when you see the dextrocardia is there, then you have to see the right lung. If the right lung is hypoplastic, then put the color and see the drainage of the lower portion of the right lung. If the right inferior pulmonary veins draining into inferior vena cava, then you suspect that it is a scimitar syndrome. Then you have to confirm this one. So this is the case where there is a shift of the heart with the right lung small in size. And if you put the color, see the flow of the color, it is joining with the inferior vena cava from right lung to inferior vena cava. So this is the scimitar syndrome. So this is the flowchart when you see the enlarged retroatrial space, then you have to see for confluent vein. If confluent vein is present, then you are suspecting TAPVC. Follow the course of confluent vein, and if it is in the upper mediastinum, supracardiac type. If it is in the coronary sinus or right atrium, it's the cardiac type. And if it is in the vein which is descending and crossing the diaphragm, then you are suspecting infracardiac type of TAPVC. This is again rare case of pulmonary venous anomalies. In the 4-chamber view, you see the left atrium is grossly enlarged. One. Second thing, if you see the left lung, you see the cystic structures in the left lung. But when you put the color in that, you see that these are the vascular things. So when you see that the pulmonary artery is grossly enlarged, and when you see the communication of pulmonary artery with the pulmonary vein in the fetal lung on left side, this is the pulmonary artery venous fistula. This is the high flow in that. So this is again a very rare type of pulmonary venous connections. So you see in the fetal lung, grossly dilated, tortuous veins and arteries. So it's a pulmonary artery venous fistulas. So very rare. It may be isolated or it may be associated with hereditary hemorrhagic telangiectasia. It's a ROW syndrome. The prevalence is very, very low, 2 to 3 per 1,000 live births, 1 lakh live births. So whenever you see a cystic structure in the fetal lung, and if the left atrium is enlarged, so you think that, and if you put the color and there is a tortuosity of that vessels and color flow is there, then you suspect that there is a fistula between the pulmonary artery and vein in the fetal lung. Now comes the persistent left superior vena cava. This is also one of the common venous anomalies of the fetal heart. It's a more common variant. Prevalence is 0.3 to 0.5% in normal individuals and in 3 to 8% of congenital heart disease. It is usually isolated, but may be associated with cardiac, extracardiac anomalies associated with heterotaxy, VSD, and coarctation of aorta. If isolated, you can suspect chromosomal anomalies in 9% of cases. But whenever you see a persistent left superior vena cava, then you have to do detailed fetal echocardiography. This is the normal 3-vessel trachea view, and left superior vena cava is always on the left of the pulmonary artery. So when you suspect that, when you take a 4-chamber view, and if you see a dilated coronary sinus which opens into right atrium, then if you see carefully, then you see along the margin of the left atrium, you see a circular ring-like structure. So this is the persistent left superior vena cava. So when you take a 3-vessel trachea view, 4th vessel is seen, which is left of the pulmonary artery. And when put the color in the right SVC and left SVC in persistent left superior cava are always same. Don't be confused with the vertical vein in TAPVC, because in vertical vein, the direction of the flow is opposite. So when you take a 4-chamber view, you get the dilated coronary sinus opening to right atrium, most of the times they mistaken like a AV canal defect, atrial septal defect. So in such cases, when there is a left-sided superior vena cava, the brachiocephalic vein is absent. This is the isolated case where you see only ring-like structure. 3-vessel trachea view, 4th vessel is seen, which is posterior to the pulmonary artery. And when you take a parasietal section, the vein is draining into right atrium. It's like a J-shaped structure. So it's a persistent left superior vena cava. This is the isolated variety. The direction of flow in right and SVC is present. Another case here, 3-vessel trachea view, but the arrangement is disturbed. From right to left, first is the trachea, second is the aorta, pulmonary artery, and then another is the persistent left superior vena cava. So here the right SVC is absent. Only on one side, left superior vena cava is seen. These are the combinations in which. So this is again a rare variant. It may be associated with some congenital heart disease also. Here, the left superior vena cava associated with right aortic arch. So trachea is in between the aorta and pulmonary artery. Here in three vessel trachea view, left superior vena cava, right superior vena cava, but only a single large trunk is seen on left of the trachea. So this is the common arterial trunk. So these are the various associations with left superior vena cava. Now comes the most important is the interruption of the inferior vena cava. Whenever you see an interrupted inferior vena cava, then you suspect that you are dealing with a heterotaxis syndrome in most of the cases, 90% of the cases. But in few cases, they are isolated variants of interrupted IVC. They are not associated with heterotaxia or any other conditions, but the prognosis in isolated cases of interrupted IVC are very, very good. So you must know about the variant of interrupted IVC in isolated. It may be azygous continuation or a hemiazygous continuation. So azygous continuation is always on the right side of the aorta, and hemiazygous is always on the left side of the aorta. Either one of the vein is dilated whenever you see a interrupted IVC in isolated cases. So when you take a transabdominal section, and if you see a double vessel sign, and if you see carefully the position of that vein and aorta. So whenever a vein which is on right of the aorta, that is the azygous vein, if the vein is on left of the aorta, it is the hemiazygous vein. This is the most important differentiating feature of this one. So this is the case here. So when you take a transabdominal section, you see the two vessels, double vessel sign in transabdominal section. One is aorta and another vein which is dilated on right of this vein is the azygous vein. So this is the first clue that you are dealing with the interrupted IVC. When you take a bicaval view, only SVC is seen, the IVC is not seen. These are the hepatic veins and ductus. And when you take a sagittal section in the thoracic region, you see a double vessel parallelly running and opening into the superior vena cava. So this is the azygous vein. In four-chamber view, area behind the heart, you see a vein which is on right of the aorta. So this is the azygous vein dilatation. So IVC absent with azygous vein dilatation, but the cardiac structures are normal. So there is no cardiac anomalies, and the atrial appendages are of normal, means left is on left side, atrial appendage right is on the right side. So there is no CHD. Only variant is the isolated interrupted IVC. You have to, in such cases, you have to continue the pregnancy and prognosis is good if there is no cardiac anomalies. Another case, again, when you take a transabdominal section, double vessel sign. So vein is on the right of the aorta, area behind the heart. Again, you see two vessels. So double vessel sign in transabdominal, double vessel sign in four-chamber view. It gives the hint that you are dealing with the inferior interrupted IVC. When you take a sagittal section and put the color and confirm that the direction of the blood flow in both the veins, one is blue and one is red. Here again, atrial appendages to left and on right also left atrial appendage. So bilateral left sideness. So this gives the hint that you are dealing with a left-sided isomerism and associated with complex cardiac defect with bradycardia. So here heart rate is very slow with a large defect. One thing. Second, left atrial appendages on both sides. And third thing, double vessel sign. So and three vessel trachea shows that you are dealing with a aortic atresia. So reversal of flow. So this is the left isomerism case. Another rare case I want to show that this is the normal arrangement. Okay, this is the common iliac veins drains into inferior vena cava and this one. Sometimes you see a double inferior vena cava. The right common iliac vein drain into right IVC, left common iliac vein into left IVC. And at the level of renal, this right IVC is interrupted. The left IVC continues with the hemiazygous vein. And also azygous vein is also interrupted. So what happened? Double IVC with right IVC interrupted, also azygous vein interrupted. So what happened? The blood flow from the lower portion goes to the hemiazygous vein. So I will suspect in such cases. Take a transabdominal section and take a double vessel sign. Now see here, the vein is on left of the aorta. Previous cases, the vein is on right of the aorta. Here the vein is on left of the aorta. So this is the hemiazygous vein. When you take a sagittal section, See, the inferior vena cava is not seen. In this infundibulum, so, the only ductus venosus and left hepatic vein is opening. IVC is not there. So interrupted IVC with suspecting hemiazygous dilatation. And when you take a lower portion, lower abdomen, you see this veins adjacent to the aorta on both sides. On one side, right side, on left side. So these are the double IVC. The right common iliac vein and left common iliac vein opens into respective inferior vena cava. Inferior vena cava. When you take a section at the lower abdomen at the urinary bladder level, if you see carefully, adjacent to the aorta on both sides, on right and left, vena cavas are seen. So double IVC. So when you trace in the mid portion at the level of renal, you see the right renal vein drain into azygous right side, and left renal vein drains into left IVC. And then if you trace upwards up to the cardiac level, you see that the coronary sinus is grossly dilated, and the area behind that you see a double vessel where the vein is on left of the aorta. So left of the aorta is a hemiazygous vein. So hemiazygous vein dilatation, no azygous vein dilatation, and that vein opens into the coronary sinus. If you see carefully here, this is the persistent left superior vena cava. So this is the hemiazygous vein drain into left SVC, and then left SVC into coronary sinus, and that coronary sinus into right atrium. So this is the very, very rare variant of the interrupted IVC, but there is no structural cardiac defect, no isomerism, heterotaxis. So only isolated variety of interrupted IVC. So it's a very good prognosis in such cases. So cardiac venous anomalies are very rare, difficult to diagnose. If you follow standard protocol, it's very easy to diagnose, and timely intervention is very, very important in such cases. Thank you.
Thanks, Sunil, for this absolute wonderful masterclass on venous anomalies. Your presentation was very, very comprehensive. The cases were very delightful. Thank you so much.
Thank you, Alok. Thank you very much.
Now I would like to call upon Dr. Raghavendra. Raghavendra, yeah, please start sharing your screen. So Dr. Raghavendra is a consultant radiologist in Bellary, Karnataka. He is a very active executive committee member of SFM Karnataka, made various presentations on state and national, international conferences. And you have to see his images to believe what he can do. And if he enters an image in a competition, he ends up winning them. And he was the co-author with me on SFM Handbook of Fetal Cardiac Anomalies. And today he'll be speaking on malposition of great arteries, which is a very confusing topic. What is the spectrum and significance? So over to you, Raghavendra. Dr. Raghavendra, are you there?
Oh, sorry, sir. Yeah,
Yes.
Thank you, sir. Thank you for your kind words of introduction. Am I audible, sir?
Yes, you are. Please move on to the next slide.
Yes, sir. Thank you, sir. Very good evening to everyone. In the next 20 minutes, I will be presenting on spectrum of abnormalities associated with malposed great arteries and their clinical significance. So let me start with how the great arteries are positioned. Normally, the blood which enters from the left atrium into the left ventricle through the mitral valve enters into the aorta through aortic valve. Similarly, the blood which enters from the right atrium into the right ventricles through the tricuspid valve enters into the pulmonary artery through pulmonary valve. So these aorta and pulmonary arteries together, they are called great arteries. So great arteries are anterior-posterior to each other. Aorta is anterior, and the aorta which takes origin from the left posterior ventricle is posterior, and the pulmonary artery which takes origin from the right anterior ventricle is anterior to the aorta. So in addition to this anterior-posterior positioning, both great arteries crisscross each other. This is why, because aorta, after taking origin from left ventricle, it points towards the fetal right shoulder and then goes posterior towards the fetal spine. Similarly, the pulmonary artery, after taking origin from the right ventricle, it points towards the fetal left shoulder and then goes posterior towards the fetal spine. This is how normally both great arteries cross over each other. On 2D ultrasound, on axial sweep, we can see here aorta is pointing towards the fetal right shoulder and pulmonary artery is pointing towards the left shoulder. This is making clear that these arteries are perpendicular to each other. Let us review embryology in brief. Cardiac looping completes by 28th day of embryogenesis, and the truncus arteriosus, which gives rise to both great arteries, is connected with the right ventricle with the conus cordis. So during 5th week, pairs of truncal ridges develop, one on right superior border and another on left superior border. The right superior border grows distally and towards the left, and left inferior ridge grows distally and towards the right. So while growing towards the aortic sac, swellings twist around each other for 180 degrees. This is responsible for spiral course of the future septum. After complete fusion, the ridges form aortopulmonary septum, dividing the truncus into aortic and pulmonary channel. So similarly, the swellings also develop along the dorsal and 1 minute. Similarly, the swellings also grow. The similar swellings develop along the right dorsal and left ventral. So when both coni swelling are fused, the septum divides the conus into posteromedial septum, that is the outflow tract of the left ventricle, and anteromedial portion, that is the outflow tract of the right ventricle. So during this process of spiraling, normally the subpulmonic conus retains and subaortic conus resorts. If the resorption of the subaortic conus directs the aorta into the left ventricle, and retention of the subpulmonic conus retains into the right ventricle. If the subaortic conus is retained and subpulmonic conus resorbs, the aorta get connected to the right ventricle and pulmonary get direct to the left ventricle, resulting in D-TGA. If both subpulmonic and subaortic conus retained, then they were both connected to the right ventricle, resulting into the double outlet right ventricle. If both coni resolves, then both they will direct into the left ventricle, resulting into the double outlet left ventricle. So by now we are understood that both great arteries are crisscross each other and anterior crisscross each other with pulmonary artery anterior to the aorta. And we also understood the embryological basis for this crisscross. So if both great arteries are parallel at their origin instead of crisscross due to disruption of normal embryological development, then we call them as Malposition great arteries. So why does it matter? When there is malposition, there should be abnormal ventriculo-arterial connection. If aorta arises from right ventricle and pulmonary artery arises from right ventricle and pulmonary artery arises from left ventricle, then they are discordant. If pulmonary artery arises from right ventricle and aorta arises from left ventricle, and they are concordant, and if they are parallel at their origin, then they are called anatomically corrected malposition great arteries. What is this malposition? The malposition is abnormal spatial relationship of great arteries, and the key feature of malposition is parallel course of the great arteries instead of crossing over. And malposition is an important subset of conotruncal abnormalities, and these malposition great arteries are commonly associated with chromosomal and genetic disorders. Let us understand malposition and transposition. Malposition is the condition where abnormal spatial relationship of great arteries is noted, and transposition is a specific subtype of malposition in which there is discordant origin of the great arteries. So if both the great arteries take origin from the right ventricle, then it is double outlet right ventricle. If the aorta takes origin from the right ventricle and pulmonary artery takes origin from the left ventricle, then it is D-TGA. In the setting of AV discordance, if pulmonary artery takes origin from left ventricle and aorta takes origin from right ventricle, then it is LTGA. So for better understanding of the abnormalities and planning for surgical repair, it will be more useful if we use descriptive terminologies explaining ventricular connections like ventriculo-arterial concordant, ventriculo-arterial discordant, or double outlet, and the descriptive terminologies based on spatial relationship of great arteries like D malpose, L malpose, side by side, anteroposterior, and so on. So coming to the spectrum of abnormalities with malpose great arteries can be categorized into three subgroups. The conditions associated with ventriculo-arterial discordance, that is D-TGA and L-TGA, and the conditions associated with ventriculo-arterial concordance, that is anatomically corrected malpose great artery, and the conditions associated with partial ventriculo-arterial concordance with abnormal position, that is DORV spectrum. So the spectrum of abnormalities will be dealing in the subsequent slides are double outlet right ventricle, double outlet left ventricle, tricuspid atresia with VST, both D transposition and L transposition type, and single ventricular pathologies, and numerous complex combinations. So when to suspect malposition? The clues start with upper abdomen and four-chamber view when the conditions associated with heterotoxic syndromes. There is the conotruncal abnormalities with normal situs and normal fourth chamber may go clueless in most of the times. In such cases, the outflow tract views like LVOT and 3VT views can hint us most of the times. So these obvious findings like cardiac apex to right and stomach and inferior vena cava to the left can be the hint for the isomerisms where malposed arteries are associated. And also an abnormal cardiac axis is also an important clue in the fourth chamber view. And these are the conditions which can hint us so many conotruncal abnormalities. Now another view where we can get the hint for the malposed great arteries is left LVOT, left ventricular outflow tract. As we know that LVOT does not divide on axial section. If the LVOT divides an axial section, immediately we will get an idea, we will suspect the ventriculo-arterial discordance. Similarly, we know that interventricular septum continues as the anterior border of the aorta, that we call septo-aortic continuity, and disruption of this septo-aortic continuity with long axis of the aorta coming in line with the interventricular septum should raise the suspicion for the overriding great arteries, as shown here. And one more important clue in the LVOT is aortomitral continuity. So this aortomitral continuity will be lost in the DORV spectrum, but it will be retained in the tetralogy of Wallet. So another view where we can get the clues for the malposed great arteries is right ventricular outflow tract view. This right ventricular outflow tract, so when the right pulmonary artery wrapping around the aorta with right pulmonary artery and main pulmonary artery wrapping around the aorta gives gives a clear picture that both aorta and this main pulmonary artery are the perpendicular to each other. If they become parallel, this view is not possible. And another view we can get hint for the malposed great arteries is three-vessel tracheal view. We know all these anatomical descriptions, but I want to highlight three important points here. Normally, the anteroposterior height of the pulmonary artery is more than the anteroposterior height of the aorta. So in some conditions where the aorta takes origin from the anterior ventricle, the anterior posterior length of this vessel will be increased. Another hint where we can get from 3VT for the malposed great arteries is single artery single great vessel in the 3VT. In addition to that, one more point we can get is the distance between great vessel and the SVC. So let us move on to this some specific cardiac defects. So look into these conditions. So atrioventricular concordance is maintained. So morphological left ventricle is giving rise to the vessel which is branching in the axial view. Let us open the outflow tract views. Both the great arteries are parallel to each other, and the vessel which is originating from the morphological right ventricle is arching. So we understood that there is atrioventricular concordance and ventriculo-arterial discordance. Let us come to the three-vessel tracheal view. In the three-vessel tracheal view, we can see only the single vessel, single great vessel, and which is convexing towards the right. This is D-TGA. D-TGA is complete ventriculo-arterial discordance with normal atrioventricular connections. Prenatally, the foramen ovale and ductus arteriosus maintain oxygen delivery to fetal circulation, and it is a cyanotic congenital heart defect, and it is a duct dependent postnatally. So hence it requires delivery at cardiac care center because the duct patency has to be maintained till the intervention. So this prenatal diagnosis helps in timely initiation of postnatal management. Let us move on to this case. The showing both the great arteries are parallel to each other. In addition to that, we can find the VSD here. Thus, echogenic tip indicates the ventricular septal defect. When we find parallel great arteries with VSD, we need to look for the overriding. If the overriding vessel is more than 50% towards the right ventricle, then it is DORV. If it is less than 50% and if it is towards the left ventricle, it is not DORV, TGA. TGA with VSD. When TGA is associated with VSD and pulmonary stenosis, this is called complex TGA. Let us move on to this case. So on 4-chamber view, color, it is showing normal atrioventricular connections. Grayscale and color side by side showing. When we move to the outflow tracts, the posterior ventricle giving rise to the artery which is branching, and the vessel which is originating from the anterior ventricle is arching. Let us wait for the three-vessel tracheal view. And the three-vessel tracheal view, we can make out the V configuration, but this is little different than the normal. As I explained earlier, the length, anterior posterior length of the pulmonary artery is shorter than the anterior posterior length of this aorta. That indicates that aorta has moved to the anterior and it is taking origin from the anterior ventricle. So it is a type of D-TGA. Specifically, it is side-by-side TGA, which accounts for 8 to 10% of the cases. We'll move on to the next case. So on the 4-chamber view, we can make out the atrioventricular discordance. So the left atrium is connected to the right ventricle. The right ventricle is identified by two factors. One is the moderator band here, and another is apical placement of the tricuspid valve. So we got to know that there is AV discordance. Let us move to the outflow tracts. The vessel which is originating from the morphological left ventricle is dividing in the axial, and the vessel which is originating from the morphological right ventricle is arching. So both the great arteries are parallel to each other. And let us move on to the three-vessel tracheal view. We can notice there is increased distance between the great vessel and SVC. That is one of the important sign of congenitally corrected transposition type of TGA. This is a case of CC-TGA. So CC-TGA is a rare cardiac malformation with atrioventricular and ventriculo-arterial discordance. There will be both atrioventricular and ventricular arterial double discordance. And it is a physiological condition. Systemic and pulmonary circulations remain in series. Isolated CC-TGA may remain asymptomatic initially, and the risk of systemic right ventricular failure and tricuspid regurgitation may develop later in the life. Next, we'll move on to the double outlet right ventricle. Double outlet right ventricle is a family of diverse complex congenital cardiac malformation. It's a type of ventricular arterial connection in which both the great arteries arise either entirely or predominantly from the right ventricle. In addition to this, there will be loss of aortomitral continuity. So let us understand this 200 and 150 rules concept. If both the great arteries are arising entirely from the right ventricle, then it is 200%. If one artery is entirely from the right ventricle and another artery is more than 50% of its diameter of the root is from the right ventricle, then it is 150%. Then let us move on to the classification of DORV. That can be classified based on the location of VST and origin and spatial relationship of the great arteries. So we can have subbiotic VST type DORV, we can have subpulmonic type VST, and subpulmonic type VST is called Taussig Bing. TGA type can have either subpulmonic or subaortic, and we can have doubly committed VST, and we can have DORV with remote VST, and we can have the DORV in the setting of AVST or heterotoxic syndromes. And in case of TOF type, except TOF type, in all other conditions, there will be malposed great arteries. But in TOF type, the great arteries are normally oriented. Let us move on to this case. So here, what we can observe, both the great arteries are parallel to each other, and one of the great artery is overriding, and the overriding great artery is dividing in the axial. So that is overriding great artery is the pulmonary artery. So it is subpulmonic VST. So it is a type of TGA type of DOR. And both the great arteries are now. And these valves are side by side. Let us come to this case. It is a type of TGA type of DORV. That is, we can see the subpulmonic VST here, and the arching vessel, that is aorta, is taking origin from the morphological right ventricle, and then we can also notice the left axis deviation of the cardia, and we can also notice the pulmonary artery is smaller in size, and there is pulmonary stenosis. So this subpulmonic type of VST TGA is called Taussig Bing type of DORV. So DORV may be part of broader CST complex, can be associated with heterotoxic syndromes, can be associated with unbalanced AV canal, can be associated with single ventricle, can be associated with single inlet left ventricle, and so many things. Hence, this is more appropriately can be termed as a great chameleon. Now, let us come to this case. So this is the left and this is the right. Now, first, let us assess the concordance. So the left-sided ventricle is right ventricle. This is identified by moderator band and the AV apical insertion of the AV1. So here, the morphological left ventricle is on morphological right ventricle is on the left side. So there is AV discordance. Let us move on to the outflow tract view. Here, both pulmonary artery and aorta are arising from the morphological right ventricle, and they are parallel to each other, and the pulmonary artery is narrow. And this aorta is towards left. Now, let us move on to this three-vessel tracheal view. We can make out the single large vessel, and there is an increased distance between the SVC and the great vessel. So that indicates L malposition. In addition to this, we can also find the PLSVC here. Now let us move on to the another case. This case is showing unbalanced AV defect. Let us move on to the great arteries. They are parallel. They are parallel to each other, and aorta is anterior, and the pulmonary artery is posterior, and the pulmonary artery is little bit smaller in caliber, and aorta to the right and anterior and right to the aorta. So this case was also associated with TAPVC. So we can notice the vertical vein descending into this vertical vein, descending and joining the portal sinus. On color Doppler, we can see the same direction flow as the aorta. The vertical descending vein of infracardiac vein is the only vessel which can take the blood away from the heart in the direction of aorta. So this was a case of unbalanced AVSD with DORV and infracardiac type of TAPVC. Let us move on to the univentricular pathologies with Malposition great arteries. So there are three types of univentricular heart. So it can be double inlet, single inlet, or common inlet. In double inlet, we can have 2 atria and 1 ventricle and 2 AV valves. In single inlet, we can have 2 atria, single ventricle, and single AV valve. In common inlet, we can have 1 atria, 1 ventricle, and 1 AV valve. So double inlet left ventricle. It is a univentricular heart where both atria connected to the same ventricle, and morphological right ventricle may be left ventricle, it is most commonly, or right ventricle, rarely, or it can be a indeterminate. And there are three types of univentricular heart. The type 1 has got normal orientation of the vessels, that is called Holmes heart, which accounts for 8%. And type 2 is right anterior aorta with rightward subaortic outlet ventricle. And type 3 is left anterior aorta with leftward subaortic outlet ventricle. Now let us move on to this case. Here we can see both the inlets are opening into the common ventricle. We can see here. Let us switch on the color. On the color also we can see both the inlets are opening into this common ventricle. On the great arteries views, both the great arteries are side by side. We can see the both valves together here. So that indicates that the great arteries are malposed. So this is a case of double inlet, double outlet ventricle. Next is the tricuspid atresia. Tricuspid atresia is nothing but an absence of direct communication between right atrium and right ventricle, and VSD is nearly present. We have three types here: type 1, type 2, and type 3. And type 3 has got associated with transposition, either D or L transposition. Now let us see this case. So here mitral valve is patent and tricuspid valve is not opening. We can see in the both grain color as well. Now let us move on to the outflow tract. Okay. This pulmonary artery is taking origin from the morphological right ventricle. Sorry, morphological left ventricle. So now let us come to this great arteries views. Both the great arteries are parallel to each other, and this the branching artery, that is pulmonary artery, is originating from the morphological left ventricle, and the arching vessel is originating from the morphological right ventricle. Hence, this is a case of tricuspid atresia with demalposition of the great arteries. Now let us see this case. This is the left side and this is the right side. On the 4-chamber view, we can see one valve is opening and other valve is not opening. The valve which is opening is the mitral valve, and the valve which is not opening is the tricuspid valve. In addition to that, in the 4-chamber view, we can also see the retrocardiac vein, which joins the coronary sinus, actually not demonstrated in this picture. So we'll come to the outflow tract views. So both aorta and pulmonary artery are arising from the same ventricle, And we can also notice the distance between SVC and great vessel in 3VT is increased. So that indicates malposition of the aorta. So in all conditions, okay. Next, we'll come to the double outlet left ventricle. Double outlet left ventricle is extremely rare condition. Both aorta and pulmonary artery arise predominantly or entirely from the left ventricle. The right ventricle is small and rudimentary, and VSD is present. So let us come to this case. So on 4-chamber view, the ventricle looks almost, it is univentricle, but have a look at this portion here. It is looking little bit echogenic here. That can indicate a VSD. Now let us come to this outflow tract views. Both the great arteries are arising from the same ventricle with aorta is posterior. Pulmonary artery is posterior and aorta is anterior, and both the great arteries are pointing towards the posterior ventricle. Now we'll come to this sagittal view. We can make out here the septum with echogenic tip. So septum with echogenic tip, and also we can see the rudimentary right ventricle here. So there, the aorta is overriding and it is predominantly originating from the left ventricle, and also the pulmonary artery is also taking from the left ventricle. So this is a case of double outlet left ventricle with large VSD. Now let us come to the last case. The situs is normal. Now we'll move on to the 4-chamber view. We can notice the chamber discrepancy with right ventricle is smaller than the left ventricle. The right ventricle is identified by the moderator band here, and also the papillary muscles attaching to the apex, and outflow tracts is showing both the arteries are arising from the morphological left ventricle. Now we'll move on to the 3-vessel tracheal view. So as I already mentioned here, that the V configuration is seen, but the height of the both arteries are almost same, and they are pointing towards the posterior ventricle. So that indicates that it is originating from the posterior ventricle, that is morphological left ventricle, and this is a case of double outlet left ventricle. So conclusion, malposition of the great arteries is nothing but abnormal spatial relationship of aorta and pulmonary arteries. And instead of normal crossing over pattern, the vessels run parallel or abnormally aligned. And they are the conotruncal anomalies often associated with chromosomal and genetic abnormalities. And the conditions with malposed great arteries are the critical congenital heart diseases. Often they are ductal dependent, and sequential segmental analysis is must to decipher the complex arrangements of the structures, and prenatal diagnosis helps us counseling and plan delivery in tertiary care center. I would like to end my presentation by thanking to the mentor emeritus, Dr. Ashok Khurana sir, President sir, Mohit Shah sir, and the state president, Adinarayan sir, and state secretary, Murali sir, and the mentor of this session, Dr. Alok Krishna sir. Thank you.
Well, thanks, Raghavendra, for an insightful presentation. It's a very complex topic, the malposition and the transpositions, and your wonderful imaging, it makes it seem so simple. You showed excellent imaging and some very, very rare cases. In fact, I have never encountered them so far in my practice. So thank you so much for your excellent presentation.
Thank you, sir. Thank you so much.
And now we take a short break. We break for 5 minutes for trade partners videos. And on behalf of SFM, I would like to thank GE Healthcare for supporting this academic endeavor. So over to you, GE team.
Tech team, please.
So a video is playing on the webcast page.
Very happy.
5 minutes over. Shall we stop the video?
Yes, please.
So be ready. Putting you live in 5, 4, 3, 2, 1. So you're live again. Go ahead.
Welcome, everyone. And I hope you have found this, the session today a great academic treat. And every treat must follow a delicious dessert. And to present that delicious dessert, I call upon Dr. Shankar Dey. He's also known as Picasso of the East. He practices in a small town in West Bengal, Asansol. He's a fetal medicine specialist. He's secretary of Society of Fetal Medicine, West Bengal chapter. And his images, you have to see them to believe them. Shankar, please share your presentation, share your screen. He's a master of 3D, 4D ultrasound. And when I thought of this topic, I had only one choice, that is Shankar Dey. Over to you, Shankar. Please show us how to use 3D, 4D ultrasound in fetal cardiac imaging to get more out of ultrasound. Thank you.
So you are on mute. Shankar sir, you are on mute.
Shankar, please unmute yourself.
Yes, am I audible, sir?
Yes, please go
Right.
ahead.
Thank you for nice introduction, and good evening to all the viewers. This is what is the topic: applications of 3D 4D ultrasound in fetal cardiac evaluation. This topic is quite close to my heart also. And I will start with why we need to do the 3D 4D, because it has some advantages over 2D. It produces 3D, 4D data set. It is a complete volume. It's unlike 2D slices. And it can reduce operator dependency on operator skills and increase the independence of the operator. And there is a reproducibility that the volume can be saved, retrieved, and reanalyzed. Even can be analyzed offline, and possibility of automation, which standardizes the workflow and improves accuracy. So, how to do it? I mean, how it works. It combines the spatial 3D sweep and 3D temporal cardiac cycle info, and then it takes motorized sweep over fetal thorax, and then gated reconstruction that aligns images with fetal cardiac cycle. And finally, the CineLoop, which is produced, is the 4D data set that shows motion and function. If we want the stepwise manner, so we need to place the transducer in a fetal chest that we normally do in a fetal echo, and we need to have the good preset for the fetal echo that we already know. And fetal quiescence is very important here. We should not be there, should not be any movement. And the sweep angle is typically 25 to 45 degree for the coverage of the from upper abdomen to the end of the up to the neck. It usually can be calculated by GA plus 5 degrees. If the fetus is of 20 weeks, we need to do a angle of sweep angle of 25 degrees, like that. And maternal breath holding, we need to ask the mother so that it reduces motion artifact also. Doppler is optional, but we need to put it to understand the shunts and valves in a nice way. The same thing when we actually optimize the gain, the balance to avoid the noise or dropout, and we need to increase the frame rate. The higher is the smoother and detailed, and the sweep time, we know it's 7.5 seconds to 15 seconds. We need to trade off with the motion artifacts. If there is a slight movement, we need to keep it in a less time, and more time given gives the more resolution. So stick can be presented not only with the gray, it can be added with color power, and HD flow, added with the volume contrast over it. And we can adjust the thickness 1 to 10 millimeter like that. And you can see these images can be the grayscale one and along with the color, power, and the HD flow. So what are the different modes of the stick volumes? We can see the after getting the data set, we can visualize the 3D data in multiplanar mode, cine loop temporal rendering, and TUI, that is tomographic ultrasound imaging, inversion mode, and rendering mode of different types. In multiplanar mode, it displays 3 orthogonal planes simultaneously in the volume data set. And its standard plane reconstruction like 4-chamber LVOT, RVOT can be produced. Coronal and sagittal reconstructions are there. Measurements of cardiac structures can be done, visualizing the flow across the septal defects and evaluating valve regurgitation or stenosis, mapping direction of the flow in the outflow tracts. And in cine loop or temporal rendering, also known as, it plays the cardiac cycle as an animated loop. It assesses rhythm, valve motion, and dynamic relationship. It assesses timing and direction of the flow during the systole or diastole. It demonstrates function for the teaching or counseling reason, we can save it. For tomographic ultrasound imaging, it displays sequential parallel slices from the volume like CT or MRI. It evaluates the vessel course in a complex cardiac malformations. It can compare multiple levels simultaneously. That's the advantage. Tracing the anomalies pulmonary venous return is good for it, and assessing the arch anomalies of great is of great value added to it. Now, systemic review of the flow patterns and multiple levels that can be done. Inversion mode actually converts the echo intensity, so the fluid field structures become solid. It's a very powerful way to visualize some abnormalities like depicting cardiac chambers, vascular lumens, and abnormal communications like VSD, AVSD can be seen. Now, in the rendering mode, there may be surface or transparent rendering of the dataset for 3D appearance. Visualizing the cardiac morphology and spatial relationships, it produces a 3D representation of blood flow superimposed on the heart's anatomy. It can demonstrate spatial relationship of the vessels. It's a very good teaching tool for complex cardiac abnormalities like TGA, DORVs, and it's also very good for counseling the patients because it's very visually intuitive images can be produced. It can be automation is there by Sono VCAD or Fine technology that intelligent navigation automatically produces 9 standardized planes. It reduces operator dependency, can be easier for less experienced users, and that standardization of can be consistent, high quality fetal echo results may be there. Only thing is that you need to take a very good volume. Now, with all these advantages, there are some pitfalls also, and artifacts may be produced due to motion, mainly due to motion of the fetus and the mother. It can produce also shadowing from the rib, spine, or maternal habitus. Obesity lowers resolution, as we all know, but it can be overcome by adjusting the probe angle, sweep angle, and maternal position so that we can get a good result. These pitfalls can somewhat maybe reduced by the electronic matrix probe that is nowadays available, which is very higher cost and a newer technology. It has matrix array with thousands of crystals, independent elements there, no mechanical sweep. In electronic beam steering causes the faster acquisition 1 to 3 seconds and improved reproducibility. So higher temporal and spatial resolution supports the real-time 3D 4D imaging and real-time simultaneous orthogonal plane. As you can see in the left plane, both the orthogonal planes, we can see the VSD in a 2 orthogonal planes. And it can cause automated navigation also. So I will discuss some examples of stick application. Normally, we do that 2D ultrasound and along with the color with all the upper abdomen, fourth chamber, RVOT, LVOT, thymus, and all those typical cardiac views. But this 3D, 4D or the stick can produce some other special cardiac views that cannot be produced by the 2D only. That is the end-phase view of the atrioventricular valve, end-phase view of the interventricular septum, the basal cardiac views. This here in the multiplanar mode and the render mode, we place and produce this kind of a in-phase view of the AV valves that can be useful in some cases. You can see the normal one in the left side, and in the right one, we can see only a single valve opening and closing in the middle. That is because the heart was affected by the AVSD, atrioventricular septal defect was there. So only single valve in the from the heart. Here, the in-phase view of the atrioventricular septum we can also see, and you can just okay, we can the rendering mode. We can change the render direction to the left and right, so that we can see the septum from the right ventricle or from the left ventricle as you want it. And in the right side, you can see there is a large ventricle and the ventricular septal defect. You can see the extent of the ventricular defect, and also you can combine with the color, so then so that you can see how it looks. What is the defect exactly is in the whole septum. And this is the basal view of the heart, where we can see all the four cardiac valves. There is a tricuspid valve, mitral valve, aortic valve, and pulmonary valve, and their spatial relationship, which is very, very important for diagnosing some complex cardiac abnormalities, and for preparing for the surgeries also. Then pediatric surgeons need these views very well. We can also produce M mode that is known as stick with the stick volume, stick M mode, or the stick color M mode. For that, we from the stored images we can produce this, and this is very helpful in understanding the arrhythmic abnormalities of the fetal heart, if there is an arrhythmia or other problems. So this application can be done in the first trimester also. The stick volumes can produce the complex abnormalities or complex anomalies can be made easy to view. And you can see the pulmonary veins in the first trimester also, and also the crossing of the valves. What we need in the first trimester, we can produce these kind of images and detect abnormalities, and avoid missing the major abnormalities. Here you can see the in the left side there is a situs solitus, on the right side there is situs inversus. How it is produced, you can see that in the rendered image of a 14 weeks fetus, and this is the left side, the 12-week fetus. You can see by transparency mode, you can easily make out the where is the stomach, and you can see the left hand and right hand in front of your eye. So you just need to produce this image, and you can show that, oh, the stomach is on the left side, or the stomach is on the right side. It made easy basically with this transparency mode. In the first trimester, if we compare with the normal one, we can have abnormal one also. In the right side, you can see that tricuspid atresia, because only one flow and single inflow and single outflow you can see, and the tricuspid valve is not opening. Only one inflow is there. So this was a case of tricuspid atresia. And along with, you can see very clearly that the left side of the heart is not filling with the color, and it's very small. So this was a case of hypoplastic left heart syndrome. And you can also make out the pulmonary an intact ventricular septum. This was a pulmonary atresia with intact ventricular septum. Now go to the second trimester and beyond, where we can find not only the cardiac positions and in with the help inversion mode, HD live seal out or color stick, we can use this to produce this kind of images. And this is a case of unilateral pleural effusion, where you can see the heart is shifted towards the right side. And also we can see in a coronal view also, and we can see the stomach. So we know it is the left-sided one, and the heart is pushed to the right. There is a dextro position of the heart. Comparing with the unilateral, this is a bilateral pleural effusion. Just to put it because here the heart is in the middle. It's not pushed to any side because the defect is on the bilateral. We can also see the lung very well. So next, coming to the ventricular septal defects, in the left side, you can see the muscular VSDs mainly near apical region, and here is the mid-muscular VSD in the right side. Here we can see the insertion of the AV valves is somewhat linear, and we can see that there is a small defect in the septum primum. That is because of there is a small partial VSD. There is a small septal defect in the atrial septum, the septum primum one. We can also make out the ostium secundum covered with the foramen ovale. We can see the foramen ovale and the foramen ovale flap. This is a very interesting case with AVSD and DORV. We can make out that both the right and left both the outflows are coming from the right ventricle only in the TUI mode. And in the right side, you can see the large defect in the middle of the heart, and there is only single valve is opening and closing. So this was a case of AVSD along with DORV. Here we can make out that the artery which is coming out from the center of the heart is branching, and at the 3-vessel trachea view, only one vessel is seen, or the single vessel is seen, which is because of a transposition of the great arteries. And here this is one use of the not playing well. Say Epstein anomaly I wanted to see. Here you can see the exaggerated offset, and the tricuspid regurgitation is up to the roof of the left right atrium, and also the tricuspid valve is not completely closing because of the regurgitation jet. Sorry, it's not moving. No, this is another case where I can see the enlarged pulmonary artery along with its branches, and there is a aliasing at the level of the pulmonary valve and showing a well sign. This is a typical case of absent pulmonary valve syndrome, where you can make out this. This is another case where the pulmonary valve, we can see the valve is at the level of the valve, there is a narrowing, and also the valve is clearly seen, which is basically echogenic and thickened. And there is a doming of the valve, you can make out in the right side pane, and there is a post-stenotic dilatation mild, and which is due to pulmonary stenosis at valvular level. Please look at the right side where you can clearly visualize the valve position, its doming and its narrowing. Now in the CLA mode, we can see through the structures, and we can look behind any other structures. Because of this mode, we can understand many abnormalities nicely. So here, this is the case of tetralogy of Fallow, where you can see the perimembranous VSD very nicely. And also there is some overriding of the aorta, and pulmonary artery which is coming from the right ventricle appears to be small also. You can compare with the normal one, which is I have put in the right side. Some DV abnormal courses that can be depicted here. You can see in this case, the DV is directly training into the IVC. And in these cases, you can see there is a blind pouch only. The DV is lost in the liver. And also in the right side, you can see one that is going to the CS, that is the coronary sinus, and another one is directly to the right atrium. So these kind of a DV, abnormal DV courses can also be depicted with this technology. In this case, in the left side, we can see the arch, the three vessel trachea view. Both the arches are touching at the tip, where is there is a communication. There's the pulmonary arch and the aortic arch. Full arch is seen, but here we cannot see the full arch in case of interrupted aortic arch. It's not joining at up to the tip of the V, and by performing a detailed 3D, we can see that the arch is going along the neck of the going to the neck, and the both the arch, the ductal and the aortic arch is not I mean joining. It's separated from the there is no communication. So this was a case of interrupted aortic arch. And here we usually see the aberrant right subclavian artery in the 3VT view. And if we want, we can see the exact origin of the ARSA. The aberrant vessels can be seen coming from the anterior aspect, unlike the other neck branches, which usually comes from the top of the arch. So here this is very confirmed and going to the right side. This is a case of a double aortic arch where we can see the arch is separated and at the level and it's causing a vascular ring around the trachea. The aorta is the ascending aorta has been separated in two, and it's going towards the pulmonary to meet it, and actually it forms a vascular ring around trachea. This ring and this the where it is separated, how it is separated, that can be very well seen in these videos that can be made out by 3D 4D ultrasound by stick methods, and you can see how nicely the ring is shown, and where the arch is separated we can understand very well here. Here we can see that the pulmonary, from the pulmonary and DA, it's going from the left side, but the aortic arch, which is remain on the right side, so forming a U behind the trachea, which is because of right aortic arch, which is not normal. We know that the V should be on the left side. And for comparison, I have taken this picture. In the middle, you can see the formation of the ring, how it is happening. The left ductal arch along with the right aortic arch forming U behind the trachea. This in the middle, this is a normal three vessel view, and in the right and left, you can understand that there is the double abnormality, both the venous and the arterial abnormality. That is the ARSA, aberrant right subclavian artery, and you can also see the persistent left superior vena cava along with it. So this was a very rare case, and I have published it in our journal. You can appreciate from these images. And another rare case, you can see the aortopulmonary window, where the aorta and the pulmonary are joining in another way, not through the DA. It's coming in between. There is a communication. As you can see the IP window very clearly in the right side, how it's forming. So in these complex cases, use of stick volumes or spatial orientation and exact location and these things can be make out. Next, we have a case. You can see that the narrowing at the part of the aortic arch in the both the right and left side in the different modes only, and this is because of the coarctation of aorta. That can also be seen in different views. We can apply the stick color stick volume and produce this kind of images. You can clearly view that the aortic arch is coming out, and then it becomes suddenly very narrow, and then it again becomes normal. So at that portion, this is the coarctation of aorta. So with this, I will go forward with some future applications. You can see it. The stick can be used as AI assistance. Finally, is going to be there. Echocardiogram can be done by automatic detection and analysis. Advanced quantification and strain imaging also can be done with ejection fractions and myocardial functions we can have. And also we can produce this kind of images and also we can use this technique to understand how the heart works and what when it fails, how it is different. So in summary, I can say that 3D/4D it's complementary, not the replacement. And the stick enables offline detailed evaluation, and fine technology or the sono-VCAD, this standardizes the fetal echo and reduces operator dependency, and it improves reproducibility, efficiency, and accuracy. And thank you. Thank you so much for giving me the opportunity. Especially want to thank Dr. Sukrana sir, the head of our family, SFM family, and Dr. Alak Varsne sir and Dr. Prasanna for helping me out with this presentation. Thank you for giving me.
Thank you, Dr. Shankar, for this absolutely delightful, mesmerizing presentation. You know, you have lived up to your name of Picasso. Everybody knows who's attending this webinar why we call you Picasso. The images was simply delightful. There's only one question in everybody's mind. How do you get these images? Why can I not get these images? Thank you so much for great presentation. And now I invite the person who inspires us all to do better every day, our mentor emeritus, Purana sir, for his comments. And he will also take the questions that are there in the chat box.
Thank you, Alok, for putting this program together, for being the inspiration behind this whole program. The ideation was all yours. And my congratulations to the speakers. It was absolutely mind-blowing, if I can use a younger word, as I call it, and it's been a treat. What we've also realized is that this is something that can revolutionize our understanding of patients who actually require something very important in their life, and that is where to deliver, when to deliver, and what action to be taken immediately, because we're really now placing our finger on patients that do need that very simple intervention of prostaglandin for ductus-dependent lesions. And the kind of demonstration that each one of them has shown us today is truly tremendous. It also shows us beautifully on how we can counsel our patients far better when we use technology. There have been, of course, a whole host of questions, and we'll go through those, and then we will have some closing remarks. But congratulations to all three speakers today for the spectacular images that inspire each one of us. And of course, I must answer the last question first, and that is, we would like to make these images ourselves as well. How do we do it? I guess we will, along the line, have initially a virtual workshop, and we know we can handle this. We've done it before with GE Healthcare. We've handled over 300 people online, and Zenith has been very kind to help us out with that. But I'm sure we could start with that and then move on to city by city, because we do realize that in our midst, we have these fantastic Picassos, Salvador Dali's, the Van Goghs, etc., etc. And they not only produce fine art, but fine science as well. So getting to the questions, we have a host of questions. Some of them bear direct questions to what we have spoken and seen. And so I will give more time to those. And there are some very simple questions which I will answer in a short phrase so that we have enough time for the more direct questions. And the first one, of course, was the first of the simplest questions. And this is from Dr. Deshmukh. In which view can we definitely diagnose an inlet VSD? So Sunil, if you can let us know that, because you started the ball rolling.
Yes. So,
yeah, go ahead.
apical four-chamber view is the best way to say this one.
Absolutely, it's as simple as that. And then we go on to the general questions about an isolated echogenic intracardiac focus, which is beyond the scope of today's talk. And there was another question on dextrocardia with right aortic arch, which again is beyond the scope of today's talk. But the next question is very relevant, and this is on how to take a pulmonary venous flow velocity waveform, and this is from Anjana Savalia.
Yes, you want to take the pulmonary spectrum, pulmonary venous spectral Doppler. The best thing is that when you take a four-chamber view, put the cursor in the fetal lung where the pulmonary veins just enter to the left atrium. That is the best place to visualize. And the angle of incidence is between 20 to 40 degrees.
And tell me, if we're visualizing all four, should we insonate all four, or is usually one of them okay?
On each side, one of them on each side.
Excellent. So the next question is a very general question, but I think we'll take it up today, is what's the ideal time for a fetal echocardiography? And this is from Anisul Maula from Bangladesh. The ideal time for a fetal echocardiography. Yeah, Alok, why don't you answer that for us?
Yeah, so we try to do fetal echocardiography somewhere around 22 to 24 weeks of gestation, because by that time the heart is sufficiently large and we can see all the anatomy and connections very, very clearly. The veins are well distended and abnormalities can be very well seen. Having said that, because of the technology improvement and our understanding of the cardiac defects, we can do a good evaluation of the fetal heart starting from maybe even 12 weeks onwards, right up to 24 weeks and even beyond. So ideally, if it is an isolated investigation, we would do it somewhere around 22 to 24 weeks of gestation. But really, we need to evaluate the fetal heart at every opportunity that we get.
Excellent. Just what I was thinking of. Now, there is a whole lot of questions on the indication for an echo and how to improve echoes and evolving abnormalities and primary views in first trimester, and also views for features of tricuspid regurgitation. We'll leave that for another webinar on basic stuff. There is this question on genetic counseling and testing, which we will take up at the appropriate forum. But the one question that people want to answer is guidelines for Z-score in fetal echo. And Sunil, what do you think about Z-scores in fetal echocardiography?
It's a very important thing. Whenever you are dealing with the cardiac anomalies or in three-vessel trachea view or in a ventricular disproportion, that time Z score is very, very important for the measurements of these chambers and great arteries.
Excellent. And
And
Dr.
each
Raghavendra,
and
yes, go ahead, go ahead.
and each and every machine nowadays they have a Z score, like
Yes.
4 chambers, ventricles, and everything. So you don't have to go for the charts and everything because every machine has a Z score now. Just you
Yeah.
have to go that how to interpret is very, very important.
You know, there are scores from about 9 authors, and I tend to use Shapiro. Would everybody agree with me that Shapiro seems to be the most reliable, or does anybody have any other experience with someone who is a little more reliable? Because the applications expert can truly choose which Z score you want displayed and have that as a preset.
I think the default setting is Shapiro only. So
Yes, it is.
no,
And Shankar,
we don't tinker with that.
wonderful. And Shankar, would you agree with that?
Yes, sir. No, those words are actually produced in the machine only, and
Yes.
they are standardized.
Excellent. And Dr. Raghavendra, your opinion on Z or Z scores?
Sir, namaste.
Namaste.
So generally, I don't practice G-score, sir. If any hemodynamic disturbance, then I will go for the G-score, sir.
Excellent. So we have opinions here. We move on to the next question on the bioeffects of 3D and 4D ultrasound. We know that there are none, and we're really very, very comfortable. And then a question for Dr. Sunil Kabra. How do you look for coronary sinus abnormality? You have mentioned this quite a bit, but Shilpa Bhute would like to know a little more. Shilpa is from Nagpur.
Yes, regarding the coronary sinus, you know about the normal position of the coronary sinus, it is on the posteriorly atrioventricular groove. And normally it is not seen on fetal echo because it's very small size, like 0.5 to 2 mm up to that one. But if the flow in the coronary sinus is increased, either from a persistent left superior vena cava or from a vertical vein, okay, or from a hemiazygous vein, then the coronary sinus is grossly dilated, that which drains into right atrium. So whenever you see a dilated coronary sinus, think of most common abnormalities.
Excellent, thank you. And the next question is on how to demonstrate a subpulmonic VSDs. And Dr. Raghavendra, what do you think is an ideal situation with this question from Kohila? You'll have to unmute yourself, Raghav. Yes.
Sir, I will go with short axis view, sir. That is the best view to demonstrate subpulmonic VSTs.
Excellent. And then there is a question which says, can PLSVC and cardiac TAPVC coexist? And if yes, how to differentiate? And in isolated LSVC, do we need to do an invasive procedure? And this question is from Dr. Ghazala from Delhi. Sunil, your answer, please.
Yes, it can be happen with TAPVC with PSLVC also. There's a combinations of that one, this one also. And second thing to differentiate from PSLVC and TAPVC is that whenever you take a three-vessel trachea view, see the direction of the blood flow in the right SVC and PSLVC, and if there is a vertical vein, they are opposite to right SVC.
Excellent. And then we have a whole series of accolades from all over the world. We have appreciation coming in from Turkey. We have appreciation coming in from Bangladesh, from Zimbabwe, from Mauritius, from Iran, from Pakistan, and a whole lot of countries. And I think all of us at SFM can be truly proud that we have gone truly international. But let's not sit on our laurels. Let's move on to the next few questions. And this one is, in the case of an absence of the azygous vein, the left is always hemizygous or azygous, could be anomalously located in the right side. A clarification on what you've already told us, but if you could repeat that for us.
Yes, normally the location of azygous vein is on right of the aorta and hemiazygous vein is on the left of the aorta. Okay, whenever there is an interrupted IVC, which is above the renal vein, most of the cases are of azygous vein continuation. But rarely, if the azygous vein is also interrupted or not seen, then the whole of the blood from the lower abdomen goes to the hemiazygous vein, which is on left of the aorta in a by transabdominal and a four-chamber view.
Excellent. That answers this question, which came in all the way from Vietnam. And as you can see, there's more and more people joining the SFM family, and very proud about that. We move on to the next question, which has actually been covered extensively in the talk, and that is distinguishing between TGA and LTGA and so on. And for that, I guess the answer lies in reviewing the entire webinar that we've done today. And this will be available. We've not yet worked out the modality because, honestly speaking, we did not expect 1,700 plus people to be here with us tonight. It has been extremely satisfying, but also shocking. And so we just have to learn to accept that. And we will find out where we can then put this on our website or on the GE Healthcare website and so on. And we will let you know where you can go through all this again. This request was from Dr. Santosh from Chennai. Then the next thing is on the ideal color Doppler settings for cardiac assessment. And do we have standards or do we have different ones for different? And this is from Aditya Agarwal from Hyderabad. So perhaps Sunil can tell us that, and then we can ask Shankar and Raghavendra also.
For the cardiac presets, already they have a presets in each and every machine, but whenever you do a scanning, you need a preset so that the field of view is narrowed and you make it and stored the presets. And whenever you do a fetal echo, every time you don't have to change this one. And also every machines, they have a presets in that this one.
Yes, and Shankar, how do you use these?
For me, sir, every patient is different and every scan is different. I use my changing the presets in each and every cases as per the need. I used to change it, sir. I do not use presets mainly.
So
We
you
have
have
preset.
one basic preset and
We
then
have
you fine
basic
tune it
preset.
a lot. Yes.
Yes, I
Yeah.
fine tune in all the cases.
Excellent. And Dr. Raghavendra, your approach is similar?
I think he's having some technical difficulties.
Okay. So we'll move on to then answering more questions. There is Dr. Farzana Siddiqui from Afghanistan, who is thanking us for this program and said it's going to go a long way in handling her patients. And then again, lots and lots of accolades coming in from all over the world, including Zambia, where we didn't even know we had members from. And I guess that's the advantage of the electronic world. You don't know where some of our friends have come in from. There is, of course, a question on the so-called sweep angio. And I guess, Shankar, this is what you were showing us. And Dr. Vibha wants to use this word for, I guess, the translation cine that you were showing us. The sweep angio, as she calls it. How do you do a translation cine?
That is the translation cine is there is a function known as cine calculation. That you through that cine calculation, you can change the X or Y rotation you want, and there is a transitional method. I mean the what we see in the A plane, we navigate from up to down or left to right. You can choose, and you just put your image. You can see in the right and left panel what portion you want to keep, and then you run it. It will the transition will be shown as a movie.
Excellent, thank you. Now, the other question is A very, very nice, simple question from Dr. Manohar from Madurai. What is a hemi-anomalous pulmonary venous drainage? Sunil, your question.
Anomalous.
Anomalous pulmonary venous drainage. Do you think it would be the same as a partial anomalous?
Yes, it's a
Yes,
partial.
it's just another name for the same condition. And then there is a question from Pune from Prajakta Bangar, and she wants to know whether we need invasive testing in an isolated case of a persistent left superior vena cava.
Yes,
No.
usually we do because there are many associations. We cannot always rely on each and every ultrasound signs. That's cannot be seen. There are many smaller defects that we cannot sometimes visualize. So better to do to confirm the genetic makeup of the fetus.
Excellent.
Really debatable topic, actually, whether to do PLSVC testing for subtle abnormalities like PLSVC. I think people will have different opinions on that.
That is true, but as a general guidance note, the question is that one can actually give our counseling, if I may say so,
Correct.
Appropriately. That look, there are rare things which we rarely find, and for which, because now invasive testing is so safe, we can offer it to you, but also we can manage quite easily without getting too worried about this. Yeah. And so that would be the best. Now, thank you so much. That's all the questions we have. And for closing remarks, first over to our president, Dr. Mohit Shah, and then closing remarks by Dr. Alok Varshney.
We can also invite Dr. Bimal sir. He's been there with us. I think he's itching to say something. And after Mohit, I think we should listen to what Bimal sir says.
Excellent.
I think everybody has just accolades, mesmerized by the whole show. I should thank Alok for taking this through, conceptualizing and actually taking it through. Kudos to you, and kudos to the speakers today. Everybody was fantastic. The kind of impression we are creating, and the kind of speakers we are making in turn is amazing. It's quite a satisfying feeling to have such a great scientific content with such beautiful images coming out of SFM. Thank you, Sunil. Thank you, Raghavendra. And Shankarda, your images were absolutely brilliant. I mean, I really, really need to have, I think you should have one small booklet about your cases. It may be a synopsis of your 3D cases, but it's just mind-boggling. You can think of creating an ebook out of it. Thank you so much.
Thank you, sir.
I enjoyed the entire session. Thank you very much.
Thank you, sir.
So, Bimal, your turn.
I actually, I have no words. This is something probably, we didn't even dream of that, we would have a day where we have, more than 1,700 people lining up for a online program. And my hearty congratulations to all the three speakers. Of course, to Alok for, definitely, I know he puts in a lot of efforts in this, right from selecting the topics, right from selecting the speakers and seeing that everything gets on well. And of course, if you have the head of the family who's taking care, then everything falls into place. So, my special congratulations to Khurana sir. I know all these things are. He's very passionate about people learning, and I think if this is the kind of substance that we pass on, not just to our countrymen, but we're passing on to the world. I think one of his wishes is on the way to be fulfilled. And so thank you very much, everyone, all the delegates who have joined in. And actually, you are increasing our problems. I know now we will have to work harder because the expectations are going to be higher, and I'm sure that the next webinar that you come for, you will find that things are definitely of the same standard that you witnessed today. Thank you very much.
Thank you, sir, for your comments. You are always inspiring to all of us. The original OG. All right, so I think we have come to the end of the program, and this has been a truly remarkable evening. And because when we talk about the next gen experts, what is our criteria of selecting next gen speakers? So we have to find people who we want to showcase their work, and we know that they are excellent in their imaging, their work, and they have been really part of the SFM family right from the get-go. They are the people who, when we call to present on various platforms, they are always ready to do it. So that is why we know that we have to really showcase their work and present them to the world, so that one day they can be the stars of the universe. With that, I think we would like to thank our co-partners here, GE Healthcare team, who have graciously taken up this academic venture of ours, and they have allowed us to reach more and more people, in fact, around the world. We are not only in India, we are now being, circulating throughout the entire world. And I hope that with their support, we will be reaching even far more places. Thank you so much. Good night, everyone. Khurana sir, final comments from you?
Well, I'm completely overwhelmed, and I so look forward to the whole series that is coming up. We plan to take this on for the whole year, and we look forward to great partnerships and to great new showcasing of talent amongst ourselves to the whole world. Thank you, Alok, for putting this together.
Thank you. Thank you.
Thank you, everyone.
Good night. Good night.
Good night. Good night.
Good night. Good night.
Thank you.
Okay, so we are now off air and video is playing on the webcast page. Thank you.
Great.
Can we have the final head count of people who joined?
They were coming and going. So
Yeah.
we had 1,750 plus. And at any given time, the average was close to between 850 and 1,000 who were on at any given time.
Fantastic.
I mean, like amazing, absolutely.
Amazing.
20 years ago, I wouldn't have even looked at this topic saying it's too advanced for me.
Amazing. Amazing.
Yeah.
Yeah, it's really, really fantastic.
Yeah, but it puts some a bit of pressure for the upcoming.
Definitely. Upcoming ones. Yeah.
The
puts
ones
pressure.
down the line will really have to perform, and we'll have, luckily we have criteria. So because we have our great, academic committee, etc., but we will have to make sure that everybody is well rehearsed. And
Yeah.
now we have 3
Sir,
more
I
mentors. We
especially
have,
want to thank Dr. Alok Bharsne, sir.
isn't he fantastic? Purely my
Because
discovery, you know that, no? Yes.
yes, sir. He has actually put a lot of pressure on me. That
Now you know.
you have to do it.
He's been putting a
Yeah.
lot of pressure on so many people at the moment.
The
Because
whole
of him
idea
only,
is
I could do it, sir. He was
all
there
the
in each
slippery
and
ones will
every
have to
problem.
encounter him. And all the nice people I can handle, the slippery ones have to be handled by him.
No, because this
And
is
we have that typical Asansol syndrome, the last moment people we are. So
It was
he has done
fantastic.
a lot of effort.
because
It was
this is
unbelievable.
something. This is a national, and now it's an international platform. So the presentations, the speakers, they have to be top notch.
I didn't know it will be like this. I mean, 1700 plus, as sir said.
I did tell you, especially. I didn't tell any of the speakers because, it would have put more pressure on them. So
Yeah.
performance anxieties.
Sunil, of course, is
That's-
very familiar. He's Mr. International from the beginning.
Yeah.
Hmm.
Now,